Hi guys, so let us continue with gonorrhea. Yesterday you have seen the definition, etiology, pathophysiology, its signs and symptoms. So today we are going to discuss about the treatment. So of course, Neisseria gonorrhea is a bacteria. So these bacteria are susceptible to a variety of antibiotics. So all gonorrhea treatment regimens are recommended by CDC. So here are the list. So mostly the parenteral ceftriaxone is the only agent recommended for gonorrhea treatment. So as I mentioned just now, all the gonorrhea treatment regimens are recommended by the CDC. So this consists of various oral or parenteral cephalosporins and the fluoroquinolones, which is given as a single dose. So uh, here for parenteral administration we are preferring ceftriaxone. Then in case of the coexisting chlamydial infection, which is documented in up to 50% of women and 20% of men with gonorrhea, in such cases you can also see the conditions like post-gonococcal urethritis, cervicitis and salpingitis in patients who are treated for gonorrhea. So in such patients we can treat with doxycycline or azithromycin. Then a single dose of azithromycin, that is 2 gram, is highly effective against chlamydia. Okay, so these regimens have documented efficacy in the treatment of urethral, cervical, rectal and pharyngeal infection. So for the coexisting chlamydial infection, we can provide the treatment with doxycycline or azithromycin, which is given as a single dose of 2 gram. Okay, so this is highly effective in eradicating both gonorrhea as well as chlamydia. So ceftriaxone is the only parenteral agent included in the CDC recommended first line agents for the treatment of gonorrhea and is administered intramuscularly as a single 125 milligram dose and in comparison with recommended oral antibiotics, and it is an expensive alternative. So in case of the pregnant woman who is infected with Neisseria gonorrhea, they should be treated with ceftriaxone as well. So for presumed chlamydial trachomatis infection, azithromycin or amoxicillin is the preferred treatment. So this oral therapy offers a promising alternative to the expense and the pain associated with the parenteral therapy, but it may not be preferred for all cases of the gonorrhea. So of the regimens of choice, only ceftriaxone is effective in eradicating both gonorrhea and the incubating syphilis. Okay, so the resistance to the broad spectrum of cephalosporins are recommended for the treatment of gonorrhea has not been reported. However, because of the increasing prevalence of high level resistance to fluoroquinolones in some part of the United States and the world, these agents are no longer recommended for treating infections occurred in this location. So, the preferred agents are the cephalosporins. So, the treatment of gonorrhea during the pregnancy is essential to prevent ophthalmia neonatorum. So the CDC recommends that erythromycin, that is 0.5% ophthalmic ointment, be instilled in each conjunctival sac immediately postpartum to prevent ophthalmia neonatum. So as I mentioned just now, pregnant women infected with Neisseria gonorrhea should be treated with either a cephalosporin or spectinomycin because fluoroquinolones are contraindicated. So ceftriaxone is the recommended therapy for disseminated gonorrheal infection also. In addition to that, gonococcal meningitis, endocarditis, and any type of the gonococcal infection in children. In such cases also, we can provide the treatment with the ceftriaxone. So, as I mentioned here, in case of pregnant women, gonococcal ophthalmia is highly contagious in adults and neonates, and they requires intramuscular ceftriaxone therapy. So, the single dose therapy is adequate for gonococcal conjunctivitis, although some physicians recommend continuing therapy until cultures are negative at 48 to 72 hours. And so here is the types of the infections and the recommended regimens and the alternative regimens. So in case of the uncomplicated infections of the cervix, urethra and rectum in adults, the recommended regimen is the ceftriaxone 250 milligram intramuscularly given once. Plus we can also provide azithromycin 1 gram per oral once daily, or doxycycline 100 milligram per oral twice daily for 7 days. Then alternative regimens include cefixime 400 mg per oral once daily plus azithromycin 1 gram per oral once, or doxycycline 100 mg per oral twice daily for 7 days. Then for uncomplicated infections of the pharynx, ceftriaxone 250 milligram is given intramuscularly once daily plus azithromycin 1 gram per oral once, or doxycycline 100 milligram twice daily for 7 days. So this is the recommended regimens for both uncomplicated infections of the cervix, urethra and rectum in adults, as well as the uncomplicated infections of the pharynx is the same. Okay, remember that ceftriaxone and azithromycin or doxycycline. Then in case of disseminated gonococcal infections in adults, those who are above 45 kg, the recommended regimen includes ceftriaxone 1 gram intramuscularly or IV every 24 hours. So, in cases of disseminated gonorrheal infections, patients should be hospitalized and treated initially with one of the recommended parenteral antibiotics. That means ceftriaxone, or alternate by using the alternative regimen cefotaxime. So, although marked improvement is usually noted within 48 hours of initiating the therapy, the treatment should be continued as an outpatient with one of the recommended oral antibiotics to complete at least 7 days of antibiotic therapy. Children and pregnant or lactating women should not receive fluoroquinolones because of the concern for bone and joint disorders. In case of uncomplicated infections of the cervix, urethra and the rectum in children, those who are less than or equal to 45 kg, we can provide the treatment with ceftriaxone 125 milligram, which is given through intramuscularly once daily. Then for the treatment of gonococcal conjunctivitis in adults, we can provide ceftriaxone 1 gram intramuscularly once. Then for ophthalmia neonatum, we can provide ceftriaxone 25 to 50 milligram per kg IV or IM once. So the dose should not exceed 125 milligram. In case of infants born to mothers with gonococcal infection, as a prophylaxis, we can provide erythromycin 0.5% ophthalmic ointment in a single application, and the alternative regimen include ceftriaxone 25 to 50 milligram per kg, which is given in a given through intramuscular route or IV once. So this was here also the dose should not exceed 125 milligram. So the most recommended regimen is the cephalosporins, ceftriaxone and the cephalosporins. So ceftriaxone is the third generation cephalosporin, which is given as a single small volume intramuscular injection that eradicates gonorrhea at all anatomic sites and is also safe in pregnancy. That means it comes under the pregnancy category B. So the ceftriaxone is ineffective against C. trachomatis and in the prevention of post-gonococcal urethritis, whereas ofloxacin and levofloxacin for 7 days have similar efficacy to doxycycline. So other injectable cephalosporins, notably ceftriaxone, cefoxitin, and cefotaxime, they have been found to be safe and highly effective, but they do not offer any advantage over ceftriaxone for urogenital infections, and their efficacy in pharyngeal infections is not as well as established. So a single oral dose of cefixime 400 mg is also effective in curing 92.3% of uncomplicated urogenital and anorectal gonorrhea infection. However, in 2012, the CDC no longer recommended cefixime as a first-line regimen because of concerns about declining cefixime susceptibility among urethral Neisseria gonorrhea isolates in the US during 2006 to 2011. So, there after 2012, it is no longer recommended. Then other oral cephalosporins such as cefodoxime, cefuroxime, they are not recommended because of inferior efficacy and less favorable pharmacodynamics. However, they are FDA approved to treat uncomplicated Neisseria gonorrhea. Then fluoroquinolones, they have been routinely used since the 1990s for the treatment of gonorrhea. However, the GISP has continuously documented fluoroquinolone resistance in Neisseria gonorrhea isolates, which has necessitated the changes in CDC sexually transmitted disease treatment guidelines. So because of this increased resistance, the CDC no longer recommends ciprofloxacin, levofloxacin, ofloxacin, or other fluoroquinolones for the treatment of gonorrhea. So this recommendation also extends to the treatment of gonorrhea associated conditions such as PID. Then the prescribing patterns. So the CDC's 2013 sexually transmitted disease surveillance program observed that 96.9% of the treated patients received ceftriaxone 250 mg. So the number of those treated with cefixime decreased from 5.3 to 5.3% in 2011 to 0.02% in 2013. So this decrease in cefixime use was expected as CDC recommendations to avoid use of cefixime at any dose as first-line therapy was issued in 2012. So other most prescribed medications followed in order by ceftriaxone, azithromycin, and other less frequently used drugs and cefixime. So the dual therapy with azithromycin or doxycycline was prescribed in 95.4% and 4% of those treated with ceftriaxone respectively. So the mostly recommended is the ceftriaxone. Then dual therapy with azithromycin or doxycycline is also prescribed. To make it more clear, here I will explain one case. So DS, who is the patient, okay? So he is a 23-year-old male naval officer recently stationed in the Philippines. So he has the complaints of dysuria, meatal pain, and a profuse yellow urethral discharge for 2 days. And then he admits to extramarital sex with a prostitute during the past week. So he is accompanied by his pregnant wife CS, who is asymptomatic. So DS engages in vaginal sex, but there is no history of oral or anal sex with either partner. Assuming the prostitute has gonorrhea, what is the likelihood that DS and CS have been infected? So this is the question. So here comes the answer. After 1 or 2 episodes of the unprotected vaginal intercourse with an asymptomatic infected prostitute, a man has approximately 50% risk of acquiring the urethral infection. So the risk increases with the repeated exposures and high prevalence among commercial sex workers. So the prevalence of infection in women who are secondary sex contacts with of infected men is as high as 80 to 90 percent. Therefore, the likelihood that DS and CS are infected is high. Because DS had sex with the prostitute, both DS and CS should also be tested for HIV infection. And the second question for the same patient is the what signs and symptoms in DS are consistent with the diagnosis of gonorrhea? And we have to describe the DS anticipated clinical course if he remains untreated. So the answer comes in men, gonorrhea usually becomes clinically apparent 1 to 7 days after. So in men, gonorrhea usually becomes clinically apparent 1 to 7 days after the contact with an infectious source. A pull and discharge associated with the dysuria is the first sign of infection. So the DS exhibits both the discharge, which is presumably caused by chemotactic factors such as C5a released when anti-gonococcal antibody binds complement may become more profuse and blood tinged as the infection progresses. So some strains of gonorrhea have a propensity to cause asymptomatic or minimally symptomatic infection with negative gram stain. So the patients with asymptomatic or minimally symptomatic disease may serve as reservoirs for the infection, evading treatment for prolonged periods. At one time, only women were thought to have asymptomatic gonorrhea, but now it is known that men may be asymptomatic carriers as well. So in the area before antimicrobials, gonorrhea occasionally spread to the epididymis, causing unilateral epididymitis, and the prevalence was 5% or more in patients with patients in some studies. Now, epididymitis occurs in less than 1% of men with gonorrhea. So urethral strictures after repeated attacks and the sterility after epididymitis are rare complications of gonococcal infection owing to the effectiveness of antibiotics. Now the third question comes for the same patient. Intracellular gram-negative diplogocca were seen on the gram stain of DS urethral exudate. Is any further diagnostic testing required? Here comes the answer. Demonstration of intracellular gram-negative diplococca in the gram-stained exudate confirms the diagnosis in these symptomatic men. Until recently, some experts recommended that cultures be reserved for individuals with negative gram stain of urethral exudate. However, today cultures are recommended for all patients to permit isolation and testing of the bacteria for antibiotic susceptibility. So cultures usually are performed on thermatin medium and enriched chocolate agar to which vancomycin, cholestyramine and nystatin have been added. So which I was mentioned in the laboratory test where we discussed about the culture medium. Then the cultures from the throat should be obtained if DS were exposed by exposed to the prostitute. In DS case, a urethral culture is indicated. So here comes the fourth question. Which series wife is asymptomatic and what symptoms should be would be consistent with gonorrhea in CS? So do the symptoms differ because she is pregnant, and what is the natural cause of gonorrhea in women if left untreated? So here is the answer. So the urogenital gonococcal infections in women are commonly asymptomatic because the endocervical canal is the primary site of urogenital gonococcal infection in women. So the most common symptom is vaginal discharge. Many women infected with gonorrhea have abnormalities of the cervix, including purulent or mucopurulent endocervical discharge, erythema, friability, and edema of the zone of ectopy. So the incubation period for urogenital gonorrhea in women is variable. PID is a serious complication in 10 to 20% of women with acute gonococcal infection and can lead to infertility and chronic pelvic pain. The assessment of signs and symptoms in women with gonorrhea often is confounded by non-specific signs and symptoms and high prevalence of coexisting infection, especially with the chlamydia trachomatis and trichomonas vaginalis. Although lower genital tract symptoms in women may disappear, they remain carriers of Neisseria gonorrhea and should be treated. Complications of urogenital gonorrhea in pregnancy include spontaneous abortion, premature rupture of the fetal membranes, premature delivery, and acute chorioamnionitis. And other complications include gonococcal arthritis, conjunctivitis, and ophthalmia neonatum in the newborn. For these reasons, it is critical that CS be worked up thoroughly for gonorrhea. So you might have understood now gonorrhea. Thank you.